Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Hi, Peter. Thank you very much. I'm doing well and looking forward to the podcast.
Today we have the supreme good fortune to be joined by special guest Dr. Morrey. Dr. Morrey needs no introduction to most listeners, but those of you who aren't aware, I'll briefly detail his accomplishments. After earning his medical degree from UT Galveston, Dr. Morrey completed his residency at the Mayo Clinic, while simultaneously earning a master's in biomechanics from the University of Minnesota. He then served in the U.S. Air Force before returning to the Mayo Clinic, where he remained for his career and where he served as chairman. During this time, he earned numerous awards from the Mayo Clinic, from ASES, and from the ASES. Completed multiple fellowships, including the ABC Traveling Fellowship and a Fulbright Scholarship. He served as president of the American Academy of Orthopedic Surgeons, the American Orthopedic Association, and the American Shoulder and Elbow Surgeons Society. His research contributions are too numerous to mention, with over 311 citations on PubMed. He's perhaps best known for his contribution to the elbow, where his detailed study of the biomechanics allowed him to conceptualize and develop a total elbow arthroplasty with survival equivalent to total hip arthroplasty in the setting of rheumatoid arthritis, which was a dramatic advance in care. His text, The Elbow and Its Disorders, continues to be the definitive reference for those who care for elbow problems. Dr. Morrey, thank you so much for joining us on the podcast.
Thank you, Peter and Rachel, and thank you for that nice introduction.
Dr. Morrey, thank you so much for being on our first podcast. For the listeners at home, the goal of this new ASES podcast is to discuss all things shoulder and elbow, including topics on novel surgeries, techniques, studies, and perhaps most exciting, interviewing the legends of shoulder and elbow surgery. Dr. Morrey, we were hoping to take this opportunity with our inaugural podcast to talk about the role the ASES has played in your career and what the ASES means to you. So, without further ado, our first question for you is, how has your involvement with the ASES enriched your career?
Well, as we develop our interest and progress through our career, there are a few things that become very, very obvious. And one of them we have chosen a path of continuous learning and continuous education. And one of the easiest ways to accomplish that kind of universal goal of our colleagues is to identify and to affiliate with those that are of like mind. And so as you develop a particular interest in a subspecialty, the stimulation and the opportunity to talk about areas of our practice that are of interest to us with individuals who also have similar issues or problems or questions, concerns in their practice is very stimulating and extremely valuable. We've picked a subspecialty that certainly the shoulder is represented pretty formally in the burden of disease, if you will. The elbow kind of not so much. So between those two anatomic parts, the Shoulder and Elbow Society does provide a very rewarding opportunity to communicate with individuals of like minds that have similar issues, problems, questions as we do. So we've elected a specialty that requires us to continue to learn and to continue to improve. And this is just one of the best mechanisms to achieve an essential feature of our chosen profession.
Now, Dr. Morrey, you've accomplished so much in your career. What are some of the things you've accomplished through the ASES that you're most proud of?
Well, I recognize that I've been very fortunate in my career. As you've heard so many times, timing is everything. And I came into our profession at a time, maybe you might even call it the golden times, as some have, where implants and prosthetic development was just becoming an essential part of what we did, more so even than you might say trauma management, which was the hallmark of our profession years ago. And so the timing issue gave me an opportunity to contribute to the body of knowledge, because there was very, very little known in the 70s about elbow problems, the artificial implants, as I'm sure you know, for hips and knees hips first were very successful. Knees followed shortly thereafter. The early knee implants were not successful, but it didn't take long to get the generic condylar and become successful. Those things were motivated by communication of ideas among colleagues, and societies, hip society, knee society formed around that, as did ours. And so I think that being a member of the Shoulder and Elbow Society and having an opportunity to discuss my questions and issues with colleagues, kind of distilled colleagues that were picked and chosen and were members because of their interest and their contribution, kind of gave me one up in a way of having an opportunity to relatively easily access the opinions and thoughts and ideas of others. And again, the Shoulder and Elbow is a very collegial organization, and so these inputs were provided in a very comfortable and casual manner in many instances. And so without the Shoulder and Elbow Society, I think I would have still developed my interest. I think we would have still contributed somewhat. But there's no question in my mind that I would not have been as fortunate as I have been in being able to provide some insights without the collegiality and the input of colleagues from the ASES. And if you go back and look at the first edition of the Shoulder and Elbow, I'm sorry, not the Shoulder and Elbow book, but the Elbow and its Disorders, some of the real important contributors in that first edition were individuals that I met through the Shoulder and Elbow Society, like Hugh Tullis from Houston, who was one of the early sports medicine people on the elbow that many people probably don't know today. Ralph Coonrad, one of my lifelong friends, was contributed on ulnar non-unions. Frank Jobe became a very close friend whom I met through the Shoulder and Elbow Society. And so the organization provided me you might say, an environment to identify individuals who were also contributing and interested in contributing. And then we got together, so to speak, and they were willing to contribute to the book. And that was very useful and rewarding in my career.
Dr. Morrey, thank you so much. Your contributions to the society and to shoulder and elbow surgery as a whole have been invaluable to all of us, and in particular, surgeons early on in their career learning the subtleties and nuances of the specialty. Peter and I have both really benefited from early involvement in the ASCS early on in our careers, and in particular, attending the ASCS annual meeting. Can you tell us a few things that you've learned at ASCS meetings over the years? While you've been on faculty too many times to count, are there things that you've taken away from the meetings that have helped you in caring for patients?
Well, specific recollections of pearls, so to speak, that I learned at meetings is something I haven't thought too much about. I can recall some things, though. One is I think it was only the second or third meeting of the organization, and a colleague by the name of Fred Ewald, who many may know, but sadly many may not, designed a very nice implant called the capitellar condylar. It was a non-linked total elbow. But he also was interested in non-prosthetic replacement. And so, along with another well-known designer named Peter Walker, that I hope the younger people will recognize and suspect they don't, who was one of the co-designers of the condylar knee, designed a device called a distraction device. And I remember when Fred first presented it, he presented a case report of a person from South America, a physician, who had a stiff elbow, and Fred released him, did not to an inner position, distracted the two bones, and began movement. And then he presented an outcome that some might consider to be not quite perfect, but it was kind of like the shoulder term limited goal surgery. This provided some function that heretofore was a dysfunctional extremity. And I remember that very vividly because he did not interpose any tissue. Now, I took a little different course And I did the same kind of thing with I'm talking about now alternatives to total joint in young people. And so I got the insight from Fred and Peter Walker about the interposition, and then, distraction arthroplasty. And then I added an interposition, and that created a whole option for me in my career to treat young people with the dysfunctional elbows that I thought were too young for an artificial implant or had too much of a burden in their occupation to have the limitations of a total elbow. And all that, I can tell you, the room that we were in, that meeting happened to have been in Rochester, Minnesota. And I can go to that room right now and tell you where I was sitting and where Fred was standing when he was presenting that material. So I found that to be extremely helpful in my entire career. And then I can also remember the amazement as I was sitting in the audience and listening to some of the guys that were more sports medicine oriented and showing what they could do with an arthroscope. And Buddy Savoie, who is a very prominent member of our organization, as everybody, and is also a very close personal friend, was showing the ability to release a contracted elbow, contracted capsule arthroscopically. And I had fooled around a little bit, but did not have really the courage, to be honest with you, to be as aggressive as Buddy was, because I'm sure I wasn't as good at it. And seeing what Buddy could do was a great stimulus and motivator to say, I can do that. I can take it to that level. And then fortunately, I was able to do that. So those are two specific presentations that I remember that kind of changed my practice. The third that I also recall was I was on a panel with Jimmy Andrews and some other people, and we were talking about how you handle the ulnar nerve in various circumstances. And in this instance, it was managing the ulnar nerve in medial collateral ligament reconstruction. And as you may or may not know, in the early years, this was one of the most controversial questions about the Tommy John procedures. What do you do with the ulnar nerve? And the techniques would tend to irritate the nerve. And most people may not know that about 20% of the early procedures were failures because of ulnar nerve symptoms. And so I remember Jim saying, I translated it in everybody. And that was a big insight for me because I would try to decide when to leave it and when to transpose it and all. And I thought somebody with that experience and that pressure to be operating on all these extremely high-performing professional athletes would probably have a better sense on things than I would with the patient population I was dealing with. So managing the ulnar nerve in medial collateral ligament reconstruction and the opportunities of arthroscopy and the concept of interposition arthroplasty are three things that I did not learn from the literature, but I learned from attending the ASES and during the meeting and presentations.
One of the things you touched upon, Dr. Morrey, was the camaraderie you've felt through the society and the meetings you've attended over the years. Do you have any favorite memories or stories from ASES meetings you've attended over the years?
Well, I got to tell you, I think these questions are kind of hard because I haven't thought much about it, along these lines. I remember the opportunity in Austin when I was president to sit down and visit with Frank Jobe, and Frank was a very close personal friend, and was a very sage individual. And I remember just discussing with him then in that meeting, which I happen to remember because I was responsible for the meeting. But I remember just his story and his career, and I talked to him specifically how he decided to do the Tommy John procedure, and that's kind of a treasured moment in my recollection. I also remember a meeting when very, very early in my career when we were just developing a successful total joint and talking with Ralph Coonrad about opportunities to improve his implant. And I remember how gracious he was to. I said, you know what? I think we need to kind of loosen up the articulation. It's real rigid, and our kinematic studies show that if we have some laxity, maybe we can dampen out the stresses and lessen the bone cement interface stress, lessen loosening. And I'll never forget. He said, "Well, do whatever you want." I said, and I think your implant's got a very good basic design, but a couple things could really make it get better. And I remember, and he said, "Well, Bernie, just do whatever you want." And I said, "Well, is it okay if I talk to Zimmer about it?" He says, "Oh yeah, that'd be fine." So the two of the giants that in our area were so gracious to talk to this young guy and to give him insight. And those are two of the areas that, of course, our senior men that I pray to God that the younger individuals that may be listening to this will remember their name and their memory, because we all stand on the shoulder of giants, and I certainly did. And those are two of my very favorite shoulder and elbow people, and contributed so much to our specialty, and certainly contributed to my career and as friends to my sense of friendship and identity.
Dr. Morrey, it's just incredible to hear about this insight and the years that you've been able to work with with yourself, such legends in the field, and hearing some of this. It's just amazing for Peter and myself, and I'm sure our listeners, to reflect on this. So thank you. You've had the opportunity to teach and train so many shoulder and elbow surgeons over the years, and I've had the good fortune of interacting with many who have learned under you, and their stories are incredible. And generations of patients have and are going to continue to benefit from this, and so it's just really it's a special thing. What do you think? Knowing that the ASES is really trying to focus a lot of their efforts on engaging younger members and surgeons new in practice. What do you think is the most important thing for our younger or candidate members to know about the ASES? Maybe things they might not know. What is your take on that from your experience here?
Well, again, kind of a provocative question. The first thing that I would hope that the younger individuals would recognize and identify with is that I think, at least in my opinion, this is personal opinion, that the senior members of our organization, and it's not exclusive to senior members, but I'm talking about my generation, whatever that means, had a real strong commitment to service. And as God is my witness, we actually did try to think about what's in the patient's best interest. And I think we have a special organization that's not so large as to you lose yourself in it. And I think the early leadership of our organization were, exceptional individuals that contributed so much, and they had a very strong, not just work ethic, but patient orientation. And I would hope that our younger members would not have the ability to recognize that directly, but I would hope that reality that did exist in the founding of our organization continues to pour through the subsequent membership, so that as individuals come into our organization, they can identify with a strong sense of service and a strong sense of commitment to the specialty. And one thing that I hope to especially recognize is kind of flipping it around to the leadership. And I'm very pleased Mark Frankel is going to be the incoming president, because I know him very well. In fact, he was one of my fellows. And he, I think, does demonstrate this very, very, very strongly, is a specialty organization, the identity of a person, to any organization, but as a professional, your identity to your professional organization can come about from several motivations. One of them is you identify with the people. And I think the ASES is very strong there, because so many of the individuals of leadership and the members are well known for their contributions to the area. But the real trump card that will determine whether or not somebody flourishes in the organization, identifies with it, or feels as though it's of value is you've got to consider whether or not this organization is relevant to you and to who you want to be and what you want to be. And if attending the meetings and listening to the dialogue and the presentation, and a lot of it is at the social side where you're meeting with somebody, you're talking to somebody that you didn't know before, or maybe somebody that helped train somebody or has a reputation that you want to meet. All those opportunities exist. And so one's participation in this organization in the final analysis is going to come down to something very, very simple. Is it relevant to you? And if it's relevant, then you will participate and you will grow in it. If it's not relevant, you may try to become involved and all. But if it's not relevant, why? Why would you continue? So, see, the burden goes both ways. I think there's a tremendous burden on leadership to remain relevant and to change. You've got to keep your feet moving when you're receiving the serve. So you've got to keep your feet moving if you're responsible for an organization and its strategic plan and its direction. And that direction has to recognize what's the reality of the times, and it has to read what's the reality of the future as best you can. So a professional organization like ours, the leadership has that burden of responsibility to be relevant. And then the younger individuals who are coming in have asked to join, so to speak, initially because they felt it was relevant, felt it was worth joining. And we have to make very sure as an organization that we don't disappoint the young people. And if we don't disappoint them, then they will grow. And if they grow, then the patient benefits because they're going to grow in knowledge and the desire for service.
Definitely, I think it's interesting to talk about growth and the importance of the society for professional growth. When you think back to your own growth, like if you think back to 30 years ago, did this envision? Is this where you envisioned you would be? I mean, is this something you could not even have imagined at that point?
You mean the position that I'm in now, or
Correct.
what my
where you've been, the journey you've been through?
Well, I've been asked variations of that quite a bit actually, and I'm a very simple-minded person and very simplistic, and I think I know I've been very, very fortunate. I was given certain gifts, so to speak. I'm one of my gifts. I'm partly Italian, and so I'm really passionate about stuff, and I really like what I'm doing. And I was given enough talent and energy, I guess, to be reasonably good at it. And that really helped patients. And so that motivated me. But I was in a good environment. I had exceptionally good partners that encouraged me and supported me. And then the Shoulder and Elbow Society was a great nurturing environment that supported me and nurtured me. And I think it does others as well. But as I look back in my career, I think much of my, I hate to call it success, but much of my activity is that I came in at a very good time where not much was known about the elbow. I had a passion to try to contribute. I was in a very good institution that supported that. I had exceptional colleagues in my department that supported it. I was fortunate enough to join a specialty society that stimulated it and allowed it to grow. And so I would say the ASES is one of the 3 or 4 key ingredients that allowed me to be to achieve some of the reasons that I came into medicine for. In fact, virtually all the reasons I came into medicine, I think I was able to have some degree of impact on.
Dr. Morrey, thank you so much. This next question, it might be a tough one, but that's what we're here for, is this one's about the future. Some of the major advances in shoulder and elbow surgery over the last several decades include certainly arthroscopy and in particular arthroscopic rotator cuff repair, and of course the total elbow arthroplasty and its advances in technique and design, and the reverse shoulder arthroplasty and how that's really revolutionized our ability to care for a variety of shoulder conditions. What do you see as the next big thing in shoulder or elbow surgery coming up in the next decade, and what's going to be on the forefront of our headlines and in our journals?
Well, actually, this isn't as hard as you think. to answer because I thought a lot about it. But I'm not saying my answers are right. It's just I thought about it. So in my time, first of all, it's a good question, and you characterized it very well. So in my days, joint replacement, the very first FDA-approved total joint in the United States was in March of 1969. It was done at the Mayo Clinic. It was a hip replacement done by Mark Coventry. Now, that wasn't the first hip replaced, but it was the first one done by FDA approval of the cement. So I started my residency in 71. So I was 2 years after the first joint was replaced. So total joint certainly revolutionized. And then when I was a senior resident getting ready to go into the military in 1976, arthroscopy was coming about. That was from 15 years later, roughly. So now we have arthroscopy coming in, and that revolutionized everything, just the diagnostic part. And then all of a sudden you get into all the therapeutic applications. And the thing that is so interesting of arthroscopy is continuing to evolve. I mean, all the things that are being, all the conditions that are being addressed arthroscopically, it boggles the mind. Even when you thought there was nothing left, here comes some other advances. And often they're not so much intra-articular, but they're extra-articular applications. So what else is out there that can possibly, we could possibly consider? I actually think there's two categorical arenas that we should keep our eye on. I think they're a ways off in a way, in some ways. But wait a minute, I'm going to add a third. So there's three. The first, I think, is biologics. Now, this is not a great insight in the world at all, because biologics is growing like a madman. And, you know, kind of, I know it didn't start with PRP, but a lot of us think of it. The first thing we think of is something like PRP, and then stem cells, and then you have bioengineered devices, so to speak, or products. So I think biologics is going to continue to emerge as a major force in changing the landscape of patient management, particularly in the areas of regeneration and stimulating growth on the one hand, and probably continuing to enhance osseous union on the other. A second, let me see, how do I want to do this? I may want to save I'll flip the second because I want to save the third for last. I think the second major advance is understanding the social environment that we're working in. And what do I mean by that? We cannot continue as a medical profession or subspecialty to not be aware of the financial implications of our clinical decisions. We simply have to be more cost effective in our attitudes. And if we don't, I think we're going to face major challenges that is going to suppress, and this is important, I'm not going to say our income. It's going to suppress research and our ability to develop further treatment options, because we have demonstrated that they all are very costly, and we aren't conscientious enough in the way that we are managing our patients. The success of the future of medicine is healthcare reform. And there are 4 words that define healthcare reform, in my opinion. And that's evidence-based, cost-effective. And I just don't think our profession, I don't think medicine is there, orthopedics is not there, shoulder and elbow isn't there. It's nothing against shoulder and elbow. None of us are there. So I think that's going to be impressed on us. So one of the things that I have done in my waning time at Mayo is to try to encourage individuals to do cost effectiveness analysis, so that we understand better what is the relationship of the treatment and its cost in the truest sense of the term. So I think that's called health science research, and I think health science research is going to play a bigger role in our practice, in our decision making. So I think that's going to be a second major trend. And then the third, which I think is going to trump everything, is a better understanding of what we call host variation. And if you think about it, and I thought a lot about it, because in the elbow I get a C3 fracture and I fix it, and for reasons that are obscure, the guy has an arc of motion of 20 to 130 with no pain. and the next guy has the same problem. I fix it, and he's stiff. I mean, it makes no sense. And then just think of all the instances where you see a patient come back, and the response to your surgery or whatever you've done, you say, GD, I mean, what the heck is going on here? And I think that we don't fully understand at all. We hardly understand at all the genetic variations that cause different host responses to the same stimulus. So this is a line of research that we've been involved with at Mayo when I was leaving, and that some of the younger guys are carrying on. So I think host variation. Why do people get ectopic bones? Some do, some don't. The response to surgery, response to injury, response to disease varies so widely. If we could identify through some screening process the genetic makeup that makes somebody, say, predisposed to arthrofibrosis, that should direct some kind of a treatment that allows us to avoid it. So I think those are to me the three trends. I think the biologics, the health science research that emphasizes cost effectiveness of selection of care, and then the host variation are going to be the arenas of the future.
That's God, that's awesome. That gives us so much to think about and so much to work on for the future. It sounds like we have our work cut out for us. Is there anything else that you wanted to cover? Anything else you want to discuss on this first inaugural podcast?
Well, I'm not sure who's going to be listening in, if anybody. But yes, one of the things that I feel really passionate about, and I've tried to touch on it, and I talk about it sometimes at graduations and all, is that just to encourage our colleagues who have picked this subspecialty, not to forget that we went into this specialty not for ourselves, but for others. And I'm so disappointed to see so many trends that seem to be so self-oriented. And that just cannot be what's happening. It cannot happen to medicine or to our subspecialty. And here's the thing I would like to leave maybe the attendees with. When you finish your training and you go into your practice and you go into your community and you petition for something called privileges, and then you get privileges. And unfortunately, I'm concerned that some people may mistake the word privileges for privileged. And we can't ever think of ourselves as being privileged in the negative sense. In my mind, when you get privileges as a physician, you are privileged to be a servant. So that doesn't mean you're special. It means that you serve. And that, to me, is something that it kind of underlies a whole lot of where our future direction is the attitude of our servants, the attitude of our physicians. And I honestly pray to God and would recommend that we just give some thought to why we went into our profession. And I do pray it's for the right reason, because the advance in our specialty, the success of our very special shoulder and elbow society is predicated on advances. It's also predicated on the attitude, but it is also strongly predicated on the attitude of our members. And I would hope that would be pure. And I know that sounds corny, probably, but I actually believe it.
Well, it's certainly a wonderful sentiment to end on.
Yeah, it's just incredibly insightful. And I think, I'll speak on behalf of Peter and myself, but likely all of our listeners, it doesn't sound corny to us. I think we all need to reflect on why we went into this field and what it means to truly take care of patients. And I think, none of us could have worded it any better than you. It doesn't mean we're privileged. It means that we have to serve, and we have to serve our patients. We'd really like to thank you, Dr. Morrey, for joining us today and making this inaugural podcast incredibly special for all of us. We value your experience, your insight, and your expertise, and just your influence on so many young shoulder and elbow surgeons throughout the country and throughout the world. To the listeners, thank you so much for listening in. And for Peter Chalmers, I'm Rachel Frank, and we'll see you next time.
Thank you. Thanks for having me on. I'm honored to have been participating. Thank you.